Hi, everyone, and welcome to the Muslim Sex Podcast. I have some exciting news. I want to let all of you know that I am opening up my office, my private office, where I can see you here in New York, and it will be opening at the end of this month. So this month is now June. So at the end of this month, my office will be up and running, and I would love for you to come in and see me as a patient. So go to V Health, so that is FEMMEVIEHEALTH.com, and sign up to be a member of my concierge gynecology practice. And you can also come to see me for regular visits, or if you have a problem visit, come and see me. I, of course, focus on menopause and sexual health. So if you're having any of those issues, I'd love to see you. And make sure you come in and say hi. I'd love to meet you in person. So also, the retreat is still going on. It'll be happening September 16th through the 23rd, and we only have a few spots left. So if you were thinking about coming to the retreat where we focus on nutrition and sexual health and menopausal health, you need to register today because spots are filling up. And once it's sold out, it will be sold out and we will not be taking any more participants. So make sure you go and register for that as well. Also, as always, please remember to like and share this podcast. Leave me a 5-star review so that it shows up and so that we can get the word out about menopausal and sexual health, as well as intimacy and intimacy coaching. So if you love this podcast, please make sure to leave me a 5-star review. And now on to the episode. I am an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is a continuation of my last one that was Menopause 101. And remember, this is not any type of medical advice. So if you're having any questions about perimenopause, you're wondering whether or not you're in it, or, is there something else going on, definitely seek care with your healthcare provider because they can assist you the best. And of course, this is not meant to be any type of religious advice. So if you're having any questions about your religion, please speak with your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So let's continue where we left off. So if you remember, in the last episode, we were talking about the hormones, right? And what functions the hormones serve. So we have low estrogen, we have low progesterone, we have low testosterone, kind of what happens in perimenopause. So all of these hormones start to go down. And we talked a little bit about, what happens when those hormones start to go down. So you can have, with low estrogen, you can feel bloating, you can have some breast tenderness, you can have all of those things that we talked about with the hot flashes, the night sweats, the palpitations, the headaches. You can have the genitourinary syndrome of menopause, where you have all of those, the whole vulvar region is affected. You can have decreased lubrication, you can have bone loss, you can have vaginal dryness, you can have pain with intercourse. With low progesterone, like I mentioned before, you can have irregular, heavier, and longer periods. During perimenopause, you can have some sleep disturbances, mood changes, loss of bone density, migraines. Any of those things, of course, can happen. And, like I said, there's some symptoms that you don't hear about very often, like dry eyes, joint pain, and new arthralgias or new onset anxiety or depression that can also happen with these change and fluctuations in hormones. And with testosterone, we know that women tend to experience decreased libido and decreased muscle mass. So what are the other things that can happen? What I want to tell you is that as we go through, so we go from perimenopause to menopause, you can have some short-term symptoms, and then you can get long-term diseases just simply because we don't have that estrogen, right? So we're having that decreased estrogen. And the short term symptoms that women tend to experience as this estrogen goes. So you have, like, say, like your estrogen is up here before perimenopause, and it starts to fluctuate, starts to go up and down. And as we enter menopause, right? So we have this decline of estrogen. And as we progress through the years in postmenopause, we see things that start to happen. So we know that we have the hot flashes, we have the sleep and the acute cognitive changes that happen. We know that these urogenital symptoms, right? So that decreased lubrication, pain with sex, all of those things, recurrent UTIs. So those things can start in perimenopause and definitely progress as we go through postmenopause. We also notice that some of the long term diseases that show up as we have this decrease in estrogen are cardiovascular disease. Actually, heart disease is the number one killer of women. It's not breast cancer. And that is something to remember, and something that is very, very important. So it's really important to take care of our hearts. And we see that with this decline in estrogen, you have an increased risk of cardiovascular disease. You definitely are at risk for osteoporosis. We know that we start to lose bone mass very early on in our lives. And unless we are proactively trying to build it up with increased resistance training and, making sure that we're eating enough protein, that we're eating enough, definitely, eating enough protein, that we need to continue to maintain that muscle mass. And if we're not actively trying to promote that muscle mass and trying to increase our bone density, then it's not going to happen. And definitely, as we lose that estrogen, that acceleration, that loss of bone just accelerates. So that's why it's really important to take care of our bones. And we don't want to be at risk for these hip fractures, these frailty fractures as we get older, because our bones become much weaker. There's also this increased risk of cognitive decline, of Alzheimer's and disease and dementia. And I think that that's really important to understand as well, right? We see how the estrogen affects our brain as we are going through perimenopause, and how those receptors light up in perimenopause, really searching and seeking out that estrogen. There was also another study done out of Cornell that talked about weight gain, and talked about suppressing protein, that it was cytochrome C4. It just came out. It's this new research, and they talked about whether or not, if they, it was another modality for decreasing weight gain in women during this menopausal period. So they talked about, blocking this receptor, and they conducted a study with mice, and they blocked this receptor, which they noted then prevented weight gain in these mice that they had removed the ovaries. So these mice were menopausal, and they blocked this receptor to prevent this weight gain. But they also noted that the mice in which they provided hormones, so gave them estrogen, did much better and did not gain that weight, as opposed to the mice that did not have the hormones, and also they tended to gain more weight. So really important to see the impact that we have with estrogen, and how estrogen actually prevents this midlife and this perimenopausal, menopausal weight gain that we often notice happens in women. We talked a lot about this genitourinary syndrome of menopause, but I want to tell you that, in perimenopause and menopause, we start to see, so in perimenopause, you start to see it a little bit, right? You see women with decreased lubrication. So, a lot of providers will say, oh, just go ahead and use that lubricant. And lubricants are great, right? Lubricants, there's no problem using a lubricant. Lubricant decreases friction. It makes intercourse more pleasurable for individuals. And so that's great to use a lubricant, but you're really not getting to the root cause of the problem. And the root cause of the problem is that decreased estrogen that results in basically a thinner epithelium, so thinner tissue in the vagina, decrease in smooth muscle and collagen. So that's why you get that decreased elasticity and decreased blood flow, and also decreased lactobacilli, which prevents us from having so lactobacilli is really great, right? and it prevents yeast infection in women. And also, having this estrogen also maintains a normal pH level in the vagina. And what happens is when we have that decreased estrogen, our pH also increases. And with that increasing in pH, it makes us more susceptible to, say, bacterial vaginosis or maybe some recurrent yeast infections. So that's why it's really important to use the vaginal estrogen, because that vaginal estrogen is going to prevent all of that from happening. Also, what's important to note is that most of these symptoms, this pain with intercourse, these recurrent UTIs, all of those things are attributed to the lack of estrogen that happens in menopause. And even though most of these symptoms happen in menopausal women, it can happen in any woman that has low estrogen. So, for example, somebody that's postpartum and breastfeeding, there was actually a term that was coined by Dr. Rachel Rubin and her medical students, and it was called the genitourinary syndrome of lactation. And I thought that was fantastic because we know that when women are breastfeeding, their hormones, their estrogen and progesterone are decreased to allow for that lactation to happen. And when that happens, that mother is able to breastfeed. However, it causes that same symptoms that you experience in perimenopause, menopause, specifically menopause, with that decreased lubrication. The same thing will happen in a woman that is breastfeeding because she has that decreased estrogen. So she'll experience those symptoms of perhaps pain with intercourse, decreased lubrication, decreased blood flow. And so that's why it's so important that even though this woman is not menopausal, her body is acting as if it is menopausal. And so it's important during that time for a woman to receive vaginal estrogen if she's noticing a lot of pain with intercourse. And so important for clinicians to also realize this, that yes, she's not menopausal, but her body is acting as if it is. And so you need to treat her with the vaginal estrogen, which is going to be really helpful for her and make her get rid of that vaginal dryness, that vaginal irritation, and really going to help her out. Like I mentioned, the hypoestrogenic state results in hormonal and anatomical changes in the genitourinary tract. Along with vaginal dryness, you can have pain with intercourse and reduced lubrication that is very bothersome and impacts the quality of life of women, especially those that, would like to still be sexually active. The primary goal for treating this genitourinary syndrome of menopause is to achieve the relief of all of these symptoms that women are experiencing. And of course, the first line treatment you can use for women is, lubricants and moisturizers, but you're really not getting to the root cause of the problem. And the root cause of the problem is that they don't have estrogen. And so that's why it's important to use estrogen, give them vaginal estrogen, as that really is the gold standard for these treatments. And so let's talk a little bit about, what we can do to help with these symptoms and these things going on in a woman's life in perimenopause and menopause. So a lot of times, when women go to their providers, the physicians, or perhaps the nurse practitioners don't really know how to treat patients, and they'll offer them, non-hormonal treatments. They'll give them an antidepressant for the moodiness. They'll give them gabapentin, they'll give them maybe clonidine, and those things can be used, but they're really not, again, going to the root cause. The root cause of all of these symptoms that a person is having is decreased estrogen and progesterone and even testosterone, especially if it's affecting their libido. There are definitely treatments. There's systemic hormone therapy that you can get. There's estrogen therapy. Local estrogens that we talked about, can also be the vaginal estrogen that you give cream, but also women can use a ring to get that estrogen replenished that they need for their body to get rid of some of these symptoms, right? The hot flashes and the night sweats. There are also things called selective estrogen receptor modulators, basically things that act only on certain estrogen receptors in the body and not on others. And these are really important as well. if you have, say, for example, a woman that has a history of breast cancer and she's nervous about taking hormones, obviously having a discussion, right? This is not saying that this woman, I don't know who this patient is, so I can't advise her, but knowing what the risks and the benefits are, this would be a conversation that she would have with her gynecologist and say her oncologist, and they would see that whether or not she would be a candidate for something called a SERM that would act on, that wouldn't act on the breast tissue, but would help her bones and would help ameliorate a lot of the other symptoms that she was having. So definitely things to consider. The other thing that is really important that we didn't talk about is, how this all happened. A lot of physicians are not comfortable dealing with hormones. And I think what's important to understand is that why that happened. So basically, we know that there was a study that came out in 2002, and it was called the WHI study. So it was called the Women's Health Initiative Study. And this study really changed how physicians practice medicine, and in terms of whether or not they're willing to prescribe hormone therapy to their patients. And it was a randomized placebo controlled trial to look at the effects of estrogen plus progesterone on a woman's health and see whether or not it benefits it, right? And what they noted was that this study was actually supposed to last 8.5 years, and they stopped it after 5 years because the National Heart, Lung, Blood Institute accepted the study's data and Safety Monitoring Board evaluation that the risks were outweighing the benefits for women. So this happened in 2002. So you have to remember that in 2002, you had these OBGYN residents, right? And before that study came out, everyone was prescribing hormones to women and, felt very comfortable doing so. Soon as that study came out, a whole generation of providers just were not taught how to prescribe menopause hormonal therapy anymore, right? So because their attendings and people that they were learning from were decided that hormones were not safe, and they caused breast cancer and they caused blood clots and stroke and all of these heart attacks, this and that, and so they said that no more hormone therapy. So remember, this is in 2002. So you have these residents that are going through residency, and all of a sudden their attendings are saying we can't prescribe hormone therapy. And then they go through and they don't learn how to prescribe hormone therapy. And they, in fact, try to get women off of hormone therapy. And what happens is that now those women that never received hormonal therapy are, the ones that are frail, the ones that are really, perhaps maybe in a nursing home, whatever, may have severe dementia, may have all this heart disease, all this stuff, because they never had the option to select hormones if they wanted to, because their providers didn't feel comfortable based on this data. And what happened is that so these reporters, these authors came out and said hormones are bad. We don't use them. And they said that they, increased the data that they looked at, increased heart disease, it increased breast cancer. And, what happened is that because of that, physicians didn't learn how to prescribe. Now, if you go to the same authors now, they have basically retracted what they had said before. So all this time they're saying, hormones are bad, bad, bad. And now they're saying, wait a second, we're going to go back on what we said. And now what they're saying is hormone therapy is the most effective treatment for managing vasomotor symptoms, which we already knew that. The FDA has approved that. We already know that if a woman is having hot flashes and night sweats and mood swings and all of those things, specifically hot flashes and night sweats, that hormonal therapy is the most effective treatment for managing that, right? It's basically helping to regulate the thermoregulation that happens in our brain by providing the estrogen that the receptors in the brain need to help with that regulation of temperature for our bodies. It also noted, and this is what the study authors are now saying, right? So they retracted what they said before, and now they're saying that estrogen alone decreases breast cancer risk by 23%, while reducing breast cancer death by 40%. So that is a big change. You have to think about it. Initially they said that it caused breast cancer. And so all these women came off of hormones. And now they're saying that it decreases breast cancer risk by 23% and reduces breast cancer death by 40%. That's a big 180-degree change there. Also, what they note is that estrogen alone is associated with a decreased risk of breast cancer, decreased risk of death from breast cancer, and decreased risk of death from all causes. Okay, so estrogen is really helping the whole body in what it does and really is decreasing the risk of death from all causes. There's so many benefits of hormone therapy when started within 10 years of the last menstrual period. And really what's important to see is that, listen, if you are more than 10 years out, speak with your provider, see if you're a candidate for hormonal therapy. The ideal time is within 10 years of the last menstrual period. And or less than the age of 60. Now, why is that? Well, they think that, the chronic diseases that are set to form, set to happen in the body, like, for example, the plaques that build up and the heart disease and all the stuff starts to happen and accelerates after menopause. And if it's been 10 years since your last menstrual period, a lot of times those diseases have already set in. And so, if estrogen was going to prevent that, it's probably not going to have as much of a benefit in those individuals that already have those, disease processes that have already started. So that's why they say that the best time frame to start hormonal therapy is within the 10 years of the last menstrual period. Who should be on hormonal therapy? So we know that the North American Menopause Society in 2022, ACOG in 2014, the Endocrine Society, all of those societies agree that hormone therapy is the most effective FDA approved treatment to get rid of vasomotor symptoms, including the hot flashes and night sweats, and night sweats that we know interrupt sleep and impair quality of life. Again, for women aged younger than 60 years or within 10 years of menopause onset without contraindication, so without reasons that they couldn't be on it, it's really important to at least offer this to women. And the benefit risk ratio appears favorable for the treatment of women for these bothersome symptoms. And also, really important to individualize hormone therapy or just therapy in general for women. And it should incorporate the women's health. It should incorporate their quality of life and their priorities, their personal risk factors, and their familial risk factors. So really important for physicians to see why women should be on hormones if they decide they want to be on hormones, and what benefit it is for women. Can all women benefit off of a hormonal therapy? Well, I would say that for the most part, yes, most women will benefit from hormonal therapy. Again, this is a discussion that you have with your provider. They have to take into account your risks, and the risks and benefits to you as a person. And, to me, in my head, I feel that estrogen is really preventative. It can prevent the onset of diabetes. It helps with, maintaining our cognitive function. I really think that it helps really with the quality of life of an individual. It prevents osteoporosis, all of those things. So, really talk to your provider and see if this is something that is good for you and whether or not you should take it. It also, hormonal therapy is also good for, aside from treating those vasomotor symptoms, it's good for that vulvar vaginal atrophy that we know. Basically, that genitourinary syndrome of menopause that we talked about, right? Maintaining your vulvar health. And how can we do that? We do that with vaginal estrogen. So that's why that's so important. So, for healthy, newly menopausal, symptomatic women, estrogen progesterone therapy is not only safe, but it's really effective treatment for menopausal symptoms. Obviously, do not use if you have a contraindication to estrogen, which is like an estrogen dependent cancer, blood clot, pulmonary embolism, stroke, or active liver disease. And, typically when we say all of those things, a lot of times that has to do with taking an oral estrogen. Sometimes, and so I would just discuss with your provider and see whether or not it's good for you to take. This decision to take or not take hormones obviously is based on your own risk factors and whatever you decide you want to do. So, other things that you can do hormones, besides hormones for menopausal symptoms is you can try, lifestyle changes. Some people will say that you can try cognitive behavioral therapy and see if that helps. And of course, we talked a little bit about the hormonal and non-hormonal medications that are used oftentimes for menopausal and perimenopausal symptoms. And what I want you to take away from this is really just to understand what happens in perimenopause and menopause, right? So these last two episodes were really just a really, really brief overview as to what happens in perimenopause and menopause. I want you to think about, what you may be going through at this time. I want you to decide if, estrogen is something that is right for you or it's not right for you, right? There's no right answer. It's very individualized, and you have to decide if that is something that you want to take. How do you want to live? How do you see yourself at the age of 90? And then what are the steps that you need to take to get to that version of you at the age of 90? And I want you to just think about that and then reflect on that and tell me what you think, right? Tell me if, you can always DM me. You can tell me if menopause, going through these perimenopausal symptoms, these menopausal symptoms are really inhibiting you from living your life to the fullest, right? And then what are the steps that you can take to help so that you do improve your own quality of life? I recently started a Facebook group, and feel free to look it up on Facebook. It's called It Might Be Menopause Support Group by Dr. Sadaf FemV Health. And I want you to take a look at it and search it up on Facebook and become a member, join the group, because really it takes a community to support and gather each other, right, during this important transition in our lives. I think that community is such a great way to connect with others. And so many people may be going through the same things that you are. And you can, shout out ideas and say, hey, listen, I'm doing this, I'm doing that, and just really, it's a forum to exchange ideas. It's a forum to empower and educate others, and really to give support to a community of women that is often dismissed and forgotten. So I think it's really important, and I invite you to join this Facebook group. It's called It Might Be Menopause Support Group by Dr. Sadaf. So check it out and let me know what you think. And until next time, remember, this is not meant to be any type of medical advice. So if you're having any issues with perimenopause, menopause, make sure to seek out your provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.